outset, I would like to thank all the eminent faculty. Dr. KPS sir has been my head of the department earlier also, and Dr. Lahane and Dr. Ruchi ma'am and Dr. Agni ma'am, all of them are very close, and obviously my father and Dr. SP Singh was also, I was trained under him during my senior residency days. So I would like to speak about astigmatism management in MSICS. As we all know that ophthalmology has grown by leaps and bounds, and it is not only our duty to improve the patient's vision but also to refine it. And proper management of astigmatism can lead to excellent visual outcomes. So the main aim is to achieve emetropia. So what are the goals of the surgery? Mainly it is painless visual recovery, spectacle independence. We have to correct all the pre-existing astigmatism, repeatability of the surgical result, the surgeries that we are doing, and give a sustained quality of vision to the patient. So we'll go to the basics. What the types of astigmatism, as we all know, is with the rule and against the rule. Against the rule is the one which we deal with in our patients when we are operating in cataracts, because the older patient have against the rule astigmatism. So what are the factors affecting astigmatism in SICS? It is mainly incision characteristics, use of cautery, and use and non-use of suture. Okay. And we will deal with each of them later on. And the important thing is that a proper pre-operative assessment of pre-existing astigmatism is very important. So how do we measure the astigmatism? We can measure it with retinoscopy, keratometry, and recently what we use is corneal topography. But still, in manual keratometry has still a lot of role in patients where there is poor fixation, corneal abnormalities, distorted Myers, high toric cornea, and dry cornea. In rest of the cases, we usually go for topography. So how do we correct the astigmatism in SICS? Mainly, incision characteristics is very important. The size of the incision, the larger the incision, the more the astigmatism can be corrected, and the more the astigmatism is caused also. So the smaller the incision, the lesser the flattening and lesser astigmatism cause. So the other thing is that the distance from the cornea, the farther the incision from the cornea, the lesser the astigmatism, and vice versa. The closer the incision, the more the astigmatism. So this was based on a theory which was given by Cox, and the target is to hit the astigmatically neutral zone. So what was stated was that surgically induced astigmatism is directly proportional to the length of the incision to the power of Q. And the theory is that the funnel's base is at the limbus, and as it moves away, it widens. So the incision should be made between this to give an astigmatically neutral result. So the next thing is incision type. There are multiple incision type. We can go for a superior incision, temporal, or superiotemporal incision. Superior incision is the one that we usually go for in post-graduation because it is easy to learn. There is more wound protection and lesser foreign body sensation to the patient. In temporal incision is the one that we should go for because we want to correct the against the rule astigmatism in these patients. And also it is easier in deep sockets, and the most important thing is that in future trabeculectomy patients also the conjunctiva is spared. So this concept is also based on coupling, and it states that flattening effect is achieved at the tissue and steepening is produced 90 degree away. So this gives an astigmatism of around -1 to -1.5 diopter at 90 degree if a 6.5 millimeter incision is placed at 12 o'clock. So when we flatten one meridian of the cornea, we steepen the other meridian. So we should always keep that in mind. And this was a study done by Gokhale et al. And they stated that superiotemporal incision was the one which gave the least astigmatism, which was around 0.2 diopters. And the rest of the superior incision, as we've already talked about, gives the most amount of astigmatism. So it is better to go for a temporal or a superiotemporal incision if we are thinking of correcting the astigmatism. And the length, as we all know, this is the amount of astigmatism that is usually caused, but it is mostly related to the surgeon. So the other thing is cautery. In SICS, we do use cautery. At our center, we usually do not use cautery. But if we are using cautery, we should be very careful because it may cause scleral shrinkage and scleral necrosis, which may result in more astigmatism. So how do we correct this pre-existing astigmatism? For mild cases, we operate on the steeper axis, as we've already talked about. If it is against the rule astigmatism, we operate on the temporal side. to correct the pre-existing astigmatism. And this is very important. We should keep it in mind. Even in phacoemulsification, we usually operate on the steeper axis we see from the corneal topography, and we go for the one which is steeper. So the other thing is going for a limbal relaxing incision. Usually a 90% depth is there in these incisions, and it is just given in front of the limbus. And it should always be given on the steeper meridian, as we've talked about. So this is a case where we gave limbal relaxing incision just to cancel out the incision that we made. So a superior incision is being made. We usually make the tunnel, but we do not enter the anterior chamber right now. After that, we usually have a guarded knife, which almost gives around 600 micron of depth, and we just give it in front of the limbus. So we usually give a paired incision. We can give another incision on the other side. So that depends on the amount of astigmatism that you have to correct. And this, there are multiple nomograms which we can use by Miller, Gill, and Nichemin. And also there is an online calculator with which we can get the amount of astigmatism that we want to correct, and they give you the amount of incision that you have to make. So these are the Miller's nomogram usually states that usually 1 clock hour of paired incisions of 1 diopter of corneal astigmatism will be cured. And this varies with the patient's age. If a little larger size of incision is given in a younger patient, and little lesser in the older patients. So other nomograms have also been given, which may help in deciding our surgeries. And this is also another LRI which states how much diopters you can correct, and it is a very easy nomogram to learn. So what are the advantages of this? It is mainly that it gives a lesser tendency of shift in the resultant cylindrical axis, and irregular corneal flattening and irregular astigmatism is prevented, which may be more for a arcuate incision. The other thing is that it is easier to perform, and the length is shorter and centrally rather than the centrally placed corneal relaxing incision, and it gives a consistent coupling ratio, which is very important. So the other concept is opposite clear corneal incision. This was a concept given by Liver and Dan, and they modified the standard approach of the clear corneal incision, adding an identical incision on the opposite end. So this usually corrected 1.66 plus minus 0.5 diopter of astigmatism. The technique involves creating 2 biplanar incisions, but in SICS we can just add another incision on the opposite end wherever we are operating, just to correct the amount of astigmatism that we want to correct. So the problem with this is that there is lack of predictability and absence of nomograms, but it usually corrects around 1.5 diopter of astigmatism. So in summary, if there is preoperative astigmatism, in cases where there is less than 1 diopter of astigmatism, we can go for a frown incision, which is 3 millimeter behind the cornea. If there is moderate, we go for a small incision centered along the steeper meridian, and a straighter incision will correct more. And if there is higher astigmatism, we go for a combination of small incision profile, like giving a straighter incision, a larger incision, and also adding LRIs or opposite clear corneal incision. And in post-operative, we can go for astigmatic keratotomy, wound revision, excision laser. So the take-home message, as we've talked about, we should always operate on the steeper axis to prevent the surgically induced astigmatism. And there are multiple techniques which we've already talked about. We can combine multiple techniques to give better results. Thank you.